Hello, everybody, and welcome to Hernia Patient Support Group and to our live chat discussion. So tonight we are delighted to be joined by Dr. Tanya Triantafalo from Greece, who is going to be talking to us about hiatal hernia. Welcome, Dr. Tanya, and thank you for joining us tonight. This session is being recorded and will be available to watch later on the YouTube channel. If you have any questions for Dr. Tanya, then we can either use the chat button, or if you just raise your hands, we can ask the questions yourself. Thank you. So, Dr. Tanya, thank you for joining us tonight. Hiatal hernia is one of the hernias I think that people know least about. It's something that people really struggle with when they've got them, and the symptoms can be quite debilitating for people.
Good evening. Hi, Jackie. Hi, everyone. Many thanks for the kind invitation to participate in this very fruitful, I guess, discussion tonight on hiatal hernia. I want to thank EHS for the kind invitation. And I do have a presentation to share, and I'm sure that there will be a lot of, questions from the audience or concerns, and I'm happy to address them, during the presentation or maybe afterwards. So I'm happy to, if you want to interrupt, and we can take things from there. So if I start sharing my presentation, are you able to see the slide?
Yes,
Yeah.
thank you.
Okay, so just a brief introduction to the topic, and a few words about me and the department I work in. So I have a great interest in benign and malignant esophageal and gastric disease. I work for the University of Athens in a high volume center that addresses esophageal motility disorders, gastroesophageal reflux disease, and hiatal hernia as well. So we are running diagnostic laboratory tests like manometry, pH studies, impedance studies, and things we're going to discuss later on tonight. So we are not just dealing with patients who will have an operation. We also have individuals who are under surveillance or treatment with medication, which have to be stopped and then reassessed in terms of symptoms. Nowadays, we tend to think that gastroesophageal reflux disease is the same as hiatal hernia, which is definitely not the case in every individual. So some people may have a hiatal hernia with some reflux symptoms developed, but not everyone. And reversely, not everyone who has a hiatal hernia, a reflux symptoms, will probably have a hiatal hernia. And in case your doctor says that you have been diagnosed with a hiatal hernia, rest assured that this is a very common scenario in the world map. And talking about the Western world, the States and Europe, the numbers of hiatal hernia are increasing. And maybe today we have more developed diagnostics. That's one reason. The other reason is that awareness is raising among the world. And it has been reported, for example, in the US, based on registries, that up to 35% of the general population have a hiatal hernia, regardless of the size, as an incidental finding. And that means that your doctor has ordered an X-ray or a CT scan for you for a completely different reason, and accidentally you are found with a hiatal hernia. And today we are referring to this sort of anatomy involving the gullet, the stomach, the junction between the two organs, and what is called the diaphragm, which is the respiratory muscle separating the abdomen from the chest. And if we could draw a yellow arrow between the two cavities, we would see that right below the lungs and right above the abdominal organs, you can see this very slim area that is called the diaphragm, which is naturally not intact. It does have some natural holes, some defects, And as you can see in green color, this is the esophageal foramen, or we know it as the hiatus as well. And this is where the passage of the esophagus takes place towards the abdomen. And that's how the food, for example, is allowed to pass towards the stomach. And this is the area where hiatal hernias are usually identified. This is how a sliding hiatal hernia looks like. And as you can see, a part of the proximal stomach has herniated through the esophageal foramen towards the chest. And along with the stomach, a part of the esophagus called the lower esophageal sphincter, which is a valve, a natural mechanism that prevents reflux, has also slipped towards the chest, which is not the natural location that is normally expected. And in situations where abdominal pressure is increasing, such as pregnancy or increased body weight, this effect is more easily enhanced, and reflux symptoms or reflux episodes may be increased in frequency and number during the day. And if we have a closer look at the so-called valve, apart from the upper sphincter of the esophagus that allows the food to pass through the esophageal lumen, we also have the lower esophageal sphincter that normally opens to allow the food passage towards the stomach. And after the meal, it closes, resulting in a spasm that prevents the refluxate, the gastric content, to return towards the esophageal lumen. So that's the normal physiology. And apart from the anatomy I explained, this physiology should be understood while someone is assessing an individual with a hiatal hernia. And that's one of the most important slides tonight. We know today that people with hernias may have a variety of anatomic disorders, but the main categories we are able to recognize are those four. So the vast majority of our patients will be diagnosed with the first frame of hernia. More than 90% of these individuals will have a type 1 sliding hernia, where part of the proximal stomach, if that's the diaphragm, has slipped towards the chest, along with the anti-reflux mechanism, which is the valve. Those patients are said to have more frequently reflux symptoms, and the typical reflux symptoms are heartburn, chest pain, and regurgitation. And let's get to type 2, 3, and 4. So traditionally, these three types were considered to be paraesophageal hernias, and those come with a vague variety of symptoms. So type 2 paraesophageal hernia, you can see that the anti-reflux mechanism is in place. It's correctly placed at the height of the diaphragm. However, another part of the stomach called the fundus, which is responsible for the acid production, has herniated through the hiatus towards the mediastinum through a very small hole where the stomach looks to be trapped. So those patients are said to have more frequently episodes of epigastric pain and not reflux. So those patients usually have symptoms after a meal or after lying down or being in a supine position. It means that the stomach struggles in this location and that the vessels may be compromised. And compromised vessels are translated in pain or situations of necrosis or ischemia sometimes. Now, type 3 is a mixed type. It's a combination of type 1 and 2. And those patients may have a combination of symptoms. And we reserve the term type 4 for the giant hernias, where the whole stomach has been misplaced towards the chest, as well as other organs may have already also herniated towards the chest, so that the pancreas or fat tissue or the spleen or the bowels may have also being misplaced towards the mediastinum. And there,
Tanya, sorry. Is type 2 then? Would that also be known as a rolling hernia? Hiatal hernia.
exactly,
Right.
yes. Yes, and those are very infrequent. So back to the old times, type 2, 3, and 4 were an absolute indication for a surgical repair because of the fear and the risk of strangulation and necrosis and what we call a volvulus of the stomach. So volvulus of the stomach is a fearful complication of type 4, where you can see that the stomach has kind of rotated to its own axis, has slipped, and this is where the outflow of the gastric content may be obstructed. And those patients come to us in the emergency setting with extreme pain. So these patients are in extremes and are urgently taken to theater. Nowadays, people with asymptomatic 2, 3, and 4 are not necessarily surgical patients, and that's something we can discuss later on. So if we have a closer look, type 1 looks like that in a zoom capture. You can see that the valve is way beyond the diaphragm. That's the hiatus here. Type 2 is the paraesophageal, where you can see that this part of the stomach is strangling. However, the valve is in place, so reflux is not always the case in those patients, and type 3 and 4 as previously discussed. So the reasons why these disorders happen, that's a very big discussion, and it would take hours and hours to really define which is the etiology. So some people have a combination of these bullets here. It has been said that people who have a weak diaphragm, and as compared to abdominal wall hernias, that's a quite similar mechanism, do develop more easily hernias. One mechanism that may be responsible for that is that the hiatus is becoming wider, and that can be congenital or can be the result of an injury during the lifetime. And then the valve is very important because it is the most important parameter of the anti-reflux barrier. If the valve doesn't have a good pressure to prevent reflux, then that's one risk factor for more reflux episodes. And then situations of increased abdominal pressure, such as regular heavy lifting, can further enhance the symptoms related to a hernia. Now, most of the people diagnosed with a hernia are completely asymptomatic, okay? And if we were having this discussion many years ago, regardless of the symptoms, if you had a type 2, 3, or 4 hernia, you would be a surgical candidate for repair because of the risk of strangulation or acute complications. However, a sliding hernia would be a finding for a more conservative treatment, and that is reserved for symptomatic patients. And let's go to the major categories of symptoms. So you may have developed reflux symptoms, and the typical ones are identified in 1 out of 3 patients with a sliding hernia. And those are, as previously said, heartburn, chest pain, and regurgitation. Types 2 to 4 may be identified in a patient with early satiety, feeling full after a meal, or feeling bloated a few hours after having a snack or a proper meal, and what we call indigestion, which is a very vague term that can be related to other conditions as well. So IBS is a very common diagnosis that has to be ruled out from our, workup when we assess a patient with a hernia. And it's a very easy strategy to attribute every sort of symptom to a hernia. But when we are dealing with a 1 or 2 centimeters hernia, that's not the proper approach. So we have to rule out the rest of the potential health problems that an individual may suffer from. And let's go to the critical question. When should I go to my doctor? So when your quality of life is severely compromised, and that means that you are struggling to go to work, or you are losing weight, or you cannot have a social meal with your friends, then that's the time you should take some professional advice. And then the other category that has to be pointed out is the category with what we call red flag symptoms. So there are some alarming symptoms that should be sent to the professional team for further investigation. And the first test would be endoscopy. The symptoms under this category are dysphagia, significant weight loss of acute onset, and signs of bleeding, such as vomiting or black stool. So the category of complications, and I'm sure that most of the questions will be related to this slide, are those patients with untreated, ongoing chronic reflux. And that's the sequel of inflammation and dysplasia, Barrett's esophagus, and all the process of the esophagus to adapt to the hostile acid environment. Now, apart from that, people with alarming symptoms or at risk of Barrett's will definitely have a camera test, a scope down the throat by a GI doctor. And we can go through details in terms of Barrett's esophagus later on, if you wish. There's definitely a bunch of tests that someone can undergo. Not everyone needs to do all these, and it's an individualized diagnostic pathway. So these two main categories will have an endoscopy, and I'm pointing out the category of people with risk factors, male patients over 50 years old with metabolic syndrome with a known family history related to reflux consequences, and those who are heavy smokers should probably have an endoscopy after a GI doctor appointment, who will measure the hiatal hernia if there is one, will define the type of the hernia, and of course will exclude causes of the symptoms that are irrelevant to the esophagus or the junction, such as H. pylori infection. So the guidelines say that not everyone should have an endoscopy. There are specific criteria, but once we have an endoscopy, then you have to stratify whether the patient, whether the individual has severe reflux or any of the complications of a hiatal hernia. That's how a barium swallow test looks like. So your doctor may advise you to have an oral contrast and see whether the emptying of the esophagus or the stomach is as expected, or a hiatal hernia can be easily identified during such a test. And of course, not everyone has to have a CT scan. It's a nice way to design an operation if you are opting for an anti-reflux procedure, but you would not normally have to do a CT scan unless a complication is suspected. That's a very big concern. Atypical symptoms. There is a very long list of such symptoms. Extraesophageal presentation of reflux symptoms, of hiatal hernia-related symptoms are a very confusing category that needs further investigation. And by that, I mean that head and neck doctors or GI doctors, internists are very often concerned about all these symptoms because of the frequency of hiatal hernias nowadays. However, not every patient who has cardiopulmonary issues should be suspected of having complications of reflux. So further investigation with functional tests is necessary before proceeding to PPI treatment or surgery. This is the list of the functional tests someone can undergo: planimetry, pH studies, capsules, wireless pH study, manometry. All of them are within a tailored path for each individual. And if we don't have any questions on that, which I'm sure will not be the case tonight, I'm just proceeding with an overview of the potential treatment pathways. So first thing, say, someone who has been diagnosed with hiatal hernia and has typical symptoms that are attributed to the hiatal hernia should undergo a conservative pathway for at least a month. So we advise those patients to avoid all triggers. Those could be acid meals, deep fried food, excessive exercise, lying down after a meal, heavy smoking or alcohol abuse. Those should be controlled, and the patient should quit for a month. And then
Do you do you recommend people to keep a diary of what they've done and any symptoms?
that would be ideal, yes. Yes, that would be ideal. And of course, we have a list of what to have and what to avoid eating.
What
Uh,
does that include? Because I think that's something that people struggle with.
so there you go. Um, that's the list of the things someone should avoid in the beginning. But I would say that firstly, we should focus on the behavior of eating rather than the quality of our meals. So speaking about behavior, just imagine, picture a day in your life where I'm sure that half of your meals are in a hurry. So the first advice is take your time while having a meal. Try to have frequent meals rather than one heavy meal per day. So many small meals every 2 or 3 hours, like having snacks during your day. Avoiding mixing liquids with the meal, especially those containing gas. So I know that many of you really enjoy having a Coke or soda with your exactly after your meal. So that's a no-no. That's because you are feeding your stomach with more gas. During swallowing, regardless of what you are having, we are swallowing air without realizing, and that results in bloating of your stomach. So this air has to be released somehow, and this is how belching is enhanced. So avoiding sodas, avoiding beverages within your meals would be a strong advice in the first time interval of evaluation. Then keeping your weight steady in the beginning would be wise. And for people who do have symptoms when they go to sleep, I know that trying to sleep with a lot of pillows is one measure that is usually advised. You should definitely avoid having a late night meal and allow at least 2 to 3 hours for proper digestion. What you should completely avoid during the first strict diet period is the fried buttered food, such as fish and chips or fried onions or fried meat. Fatty meals tend to have a delayed gastric emptying, so we also avoid fatty meals as well. Acidic choices such as lemon, orange, or grapefruit. And also, I know that this is one of the hardest parts: caffeine, black tea, milk, and whatever contains caffeine, such as chocolate, has to be avoided. And that is because they have been found to result in relaxation of the lower esophageal sphincter, and that will further worsen your reflux. And of course, alcohol and spices within the meals. And I know that every patient reacts in a different way. There are some categories of food that can be gradually added on after the first month of this diet. And when they have a reflux attack, as we say, reflux attack with symptoms of heartburn, then chewing a gum, mastica gum, has been found to ease the symptoms. Having a banana or a pineapple may help you out in increase heartburn. And when someone doesn't really improve after these lifestyle changes, then we have to start the test and treat strategy. And this is a very common strategy in the general population. We do have two main categories of drugs. The antacids are an over-the-counter medication that can be taken on demand, which is not the case for what we call the proton pump inhibitors. So if someone decides to undergo a PPI treatment, that cannot be an on-demand treatment. You have to be very consistent when you're having a PPI therapy, because otherwise the drug will not work once you start feeling your heartburn. So it has been advised that starting with a minimum dose of once daily, half or 1 hour before a meal, is when this drug is activated, and not after having a meal. So that's a very common misunderstanding between patients and physicians. The proper treatment would be that, starting for 2 weeks, for 2 months, and then getting an evaluation by your GI doctor or your surgeon. And the surgeon or the GI doctor will evaluate whether you had a success after having a proper treatment. And success can be translated either with the symptoms. So your heartburn is expected to respond to the PPI treatment. But if your predominant symptom is regurgitation, that will not change under a PPI course of treatment. And that is because the PPI stops acid production by the stomach. It really changes the environment within the stomach, but does not change the amount of the refluxate. So you will keep having the sensation of regurgitation, but the heartburn sensation will change, most probably. And another measure to really assess response to treatment is to have an endoscopy and see whether your esophagitis that was previously diagnosed, for example, has responded and the inflammation is getting better. And I'm not referring to patients with giant hiatal hernias who have chosen to undergo a conservative pathway, because those should be advised of, should have worsening advice. And PPI treatment is not gonna be a definitive treatment for those people. So these are the three scenarios. You either have a complete response with no recurrence of your symptoms, so you're off the hook. You either are completely dependent on the drugs, so you have to keep taking them, and the other category is no effect after the treatment. And there have been a lot of discussions over the past years in terms of side effects after chronic use of PPIs. I'm not saying that it is a catastrophic drug, because it's very helpful in chronic reflux, and it has a similar success rate compared to a successful surgical operation. But they have been accused of pneumonias because they change the environment in the stomach. So other pathogens may overgrow in the stomach, and by microaspiration, you may get pneumonia. Liver issues or sleep disturbances or malabsorption of calcium that may result in fractures have also been reported. So to summarize the main questions, can a hiatal hernia heal on its own? Well, PPIs or conservative treatment will not change that. Can hiatal hernia cause long-term problems? Type 1 may result, when reflux is untreated, may result in complications through the sequel of Barrett's dysplasia and neoplasm formation. Or for type 2 to 4, strangulation and postprandial pain may be the associated complications. But is surgery always necessary? Well, the short answer is no. I really like this slide because it summarizes the indications for surgery. There is no absolute indication for surgery nowadays. People who should have a discussion with a surgeon are those who have complications of reflux, such as Barrett's or severe inflammation of the esophagus. People who are PPI dependent and don't want to continue taking PPIs or already have side effects from the PPIs. 1 and 4 are those with extraesophageal symptoms or those who cannot respond to PPI treatment, and those two should have further investigations before proceeding to surgery. And I'm just adding those with the predominant symptom of regurgitation. Those are good candidates for an operation. And these operations tend to increase over time. We used to be very reluctant in offering a surgical repair in those patients, but the numbers are changing. And my favorite slide is this one, setting the expectations from an intervention through an anti-reflux procedure or a hiatal hernia repair. What do you wish to have as a change in your life after an anti-reflux procedure or your hernia repair? This is what I ask my patients. And everyone answers with many symptoms that need to be taken away, but you should be very clear in identifying which symptom is related to the hiatal hernia and which symptom is expected to improve. So if someone feels bloated or has a predominant symptom of belching, this is not an indication for surgery. And in fact, those symptoms will deteriorate, will worsen after an operation with an anti-reflux procedure because you are creating a valve, you enforce the lower esophageal sphincter, and belching will not be easily possible after this operation. So those patients will have increased fullness, they will feel more bloated after an anti-reflux procedure. And of course, we are addressing quality of life, and this is a very high expectation output that needs to be addressed. And I really like the optimistic side of things. However, when I'm asked about the success rate of an operation, I tend to say that 1 out of 10 patients who have a hiatal hernia repair will fail, and failure may be related to many factors. This is what we expect from an operation. We are restoring the anatomy, and to do that, we are retracting the stomach back to the abdominal position. We are closing the hiatus with stitches, and then the surgeon may decide not to proceed with an anti-reflux procedure. Sometimes we are placing a mesh, similarly to the abdominal wall reconstruction, and creating the valve the wrap technique may have some modifications depending on the patient's characteristics, and I'm not going to go through more details on that. Keyhole surgery is the way to go nowadays. So your surgeon may choose to do a laparoscopic approach or a robotic approach as well. Pain management is way easier after such an operation. You will have 4 or 5 small holes, and you are expected to get out of the hospital the next day. You're having a thorough preoperative workup, depending on your previous history or the potential motility disorders your doctor may suspect that you have developed. And in terms of postoperative instructions, we can have a discussion afterwards if you want to have more details. So, long story short, after 1 month, you are expected to go back to your normal life. And in terms of the surgical results, as I said, 90% is the success rate, and I'm referring to the functional result. Mortality and morbidity rates are extremely low nowadays. And there are two fearful complications. One is dysphagia because of a more tight valve, and the other one is recurrence. So I think that was me. These were my slides. And I'm happy to go through details if you have any concerns or questions.
Thank you, Tanya. That was really interesting description and learning lots about the different types of hiatal hernia. If anybody's got any questions, they can use the chat button or we can just ask. But when we're talking about management, I know some people think that they can manage it. I've heard people say they go and see a chiropractor. Does that work sometimes? That should be something to consider.
So, as I said, a hiatal hernia will not change unless it's surgically operated. However, we do have many strategies to really palliate the symptoms. And I know that there are a lot of discussions about physiotherapy or some specific breathing exercises or core strengthening, similarly to the way we think about abdominal wall hernias. I don't have evidence on that. I do have the experience of people who have improved over those strategies. And I'm sure that a giant hiatal hernia will probably not change in terms of daily symptoms, but someone who does have a 2 or 3 centimeters hernia and is, taking advice from a practitioner, well, it doesn't sound harmful to me if it helps in the symptoms, mostly those related to reflux, then I think it's one measurement that is not criticized.
Yeah. So you mentioned raising the head of the bed.
Mhm.
Is it the bed you raise or with extra pillows? Because that's something that some people say raise the actual bed, so put bricks or something underneath, or some just say extra pillows.
Doesn't really matter. The mechanism and the thinking behind that is the same. You allow your stomach to empty more easily,
Right.
and then you are decreasing the pressure that is causing the reflux episodes during your night sleep. So when we are in a supine position, all the pressure from the abdomen is increasing the reflux episodes. And that has been proven based on pH studies. During our night sleep, we tend to have a very delayed emptying of the acid we experience in our esophagus. And most of the people who have it are asymptomatic during their sleep. So it's a protective way towards your esophagus.
Okay. When you talk about conservatively to start using over-the-counter medication, can you over-medicate with those antacids? Can
Can
you
you?
take too many? Can you take too many of the like the antacids over the counters?
So it's about 3 times per day, the maximum dose. And as I say, it's an on-demand medication. Most of the GI doctors advise a combination between PPIs and antacids.
Okay. What about pain medication? Is there anything that patients should involve? Would like anti-inflammatories, will they make things worse? So,
So pain is the result of acid exposure. So you have to neutralize this acid
right.
because pain is the expression of, is a perception of heartburn. That is the result. So antacids and PPIs will be the ones for for pain relief. You don't
What
take
about
inflammatory drugs or paracetamol. These do not
they
improve
won't work?
reflex
What
time.
about things like apple cider vinegar or slippery elm? I know quite a lot of people have mentioned that within the Facebook group that they take the supplements.
Which are again the supplement?
There's some people take apple cider vinegar. That's supposed to be a health supplement, or a slippery elm as well. You've
No,
not heard of those?
heard those. No,
Okay.
don't have them in Scotland either.
No. So, what about after surgery? Are there any foods that should be avoided after surgery?
So, in the first days, within the first weeks, it's not about the quality of the food, it's the softness of the meals you have. So, you're advised to have a puree diet, so everything you wish to have in a smashed form for a week. And then after that, you are adding on soft diet in a normal form though. You should avoid bread or pasta or rice, and try to have your meat or fish using some light sauces so that your swallowing is easy without any difficulties. And then frequent small meals are the best way to go within the first month. And then after a month, you're expected to go back to your normal. And there are no specific categories of food you should avoid.
Why is it then that some GPs and some doctors are reluctant to treat a hiatal hernia?
I don't know. Do we have anyone here tonight? So I guess it's all because of the bad reputation anti-reflux surgery had within the past decade. And that was basically because anti-reflux procedures were offered by all general surgeons. But nowadays, we have realized the severe side effects of anti-reflux surgery. And we know the significance of performing a proper operation in the first time. So the second effort to repair a hiatal hernia that has recurred will not be as successful as the first time. So nowadays we know that very well, and we are trying to centralize this practice. And centralization is not about the surgical team only. It involves all the subspecialties that are um, that do have the expertise in hiatal hernia, a GI doctor, a nutritionist, a dietitian, special nurses that will guide those patients towards the postoperative course. Um, so I think that this bad reputation is changing nowadays.
So we always recommend to patients that they ask their surgeons about their experience. I take it this is going to be true also with hiatal hernia, that you want somebody who does quite a few of these operations.
Exactly. And the basic reason for that is that hiatal hernia, as I previously showed you in the slides, is a variety of symptoms, a variety of mechanisms, is a complex anatomy combined with functional results. So anti-reflux surgery is a functional operation. It's not just about closing the defect. It's about changing the function of the anti-reflux mechanism. And you may end up with some severe disasters when you are causing injury to the nerves of the esophagus or injury to the stomach. You may end up with some severe complications that you need to avoid. So that's why you have to see a specialized doctor.
Okay. I know we touched on it briefly earlier, but why is it that some people, their hernias are only found out because of investigations into other things? They're not actually symptomatic with their hiatal hernia.
So some of them are really asymptomatic because they they don't have any episodes in their lifetime, or they didn't have to go to the emergency department. They are eating properly. They don't have any swallowing issues, any motility disorders associated with their hiatal hernia. But others, after having the diagnosis with what is called an incidental finding, just start to realize that they were not that asymptomatic, and some of the symptoms were greatly neglected throughout their lifetime
Right.
because they were used to their symptoms. This is a quite common scenario. And then you need some professional advice to go through your symptoms and your previous medical history and really point out which symptoms are eventually related to this finding.
Does anybody else have any questions? So Edwina, yeah, absolutely.
Yeah, I do. So I have a hiatal hernia, and it's a rolling one. It's almost 10 centimeters long, and it's impacted on my lungs and against my stomach. So I'm finding it very hard to breathe. Is that normal?
So it's not normal.
Is
It's
is that is that normal with a hiatus hernia?
Oh, yeah. You mean if it's expected to have pulmonary issues, to have respiratory
Yeah.
issues?
Yeah,
Yeah.
because I can hardly walk because of it, because it's so bad and it's 10 centimeters, which I believe is quite long. So I don't have any of the things that you've been talking about with the problem with reflux. I just have a problem with breathing. Is that quite common?
It's not very common, but when having a giant hernia or a big hernia, when you have a hernia more than 5 centimeters, it is considered to be a big hernia.
Yeah.
Then it may result in cardiac arrhythmias or respiratory issues. So that's kind of expected with such a hernia.
Okay.
Whether you have to do something for that or not, you have to have some more investigation. And that could be a CT scan or some spirometry to assess your pulmonary reserve
Right.
and see
Yeah,
whether
I've had those. And they've told me that, well, I mean, they haven't really told me anything. You've probably told me more today, but I do get asthma. So we've gone down CT scans, the what do you call it, the endoscopy, yeah, endoscopy, and that's how they found out. But would you say that a 10 centimeter hiatal hernia, which is slightly strangulated, is an urgent operation? Is that urgent or not?
which is strangulated.
Slightly strangulated, apparently.
Signs of strangulation are something that should be treated in the emergency department, and that is because you may end up with necrosis of the stomach. But strangulation and respiratory consequences are a completely different scenario.
Yeah,
So respiratory disorders is something that can be discussed and can be watchful strategy, wait and see strategy. And even if you were to have an operation, you should be aware that the success rate of such an operation is less than 90%, is 70% for those treated for a hiatal hernia for respiratory symptoms. But if strangulation is the main concern, then you should be aware that this is something for the emergency department, for sure.
Yeah, so I think so too. But my doctor has told me that, well, his assistant has told me it's not urgent. Yeah, I can't walk down the
It's not
street.
urgent because you're very young and otherwise healthy, but
Excuse me, I'm 62.
but if the symptoms worsen over time, then having an operation at the age of 80 or 85, 90, which happens sometimes,
Yeah.
when you have an acute operation for a hiatal hernia, then that's not an ideal case scenario. But now you're young enough to consider having an elective repair.
Yeah, well, 62 is not young. It's just the Botox. But you think it's something that I shouldn't have to wait a year for. Sorry, we're in the NHS in London, and I've been told it could be up to a year waiting for it.
That's not too long.
Well, it is when you can't walk.
As long as you are aware of the symptoms that may take place when it gets really strangulated, or you have an outflow obstruction because of the twisting of your stomach around its axis, then 1 year is not a long time, because you've been having that for many, many years now. It's just that you now started thinking about it or investigating on it. Is that not right?
No, it came on quite quickly. So I know that the NHS is quite difficult to get an appointment, or rather an operation. But I was told it was something that needed an operation quickly. But then I found out, knowing that I was going to have it this February, I was told by his PA, it's not urgent, so you can wait up to a year. And to me, having waited almost a year for it anyway, and not being able to walk, and I do get asthma, you see, so it's extra.
Do you have any problems with your digestion? I mean,
no, not particularly.
Vomiting or losing weight, or
no, I wish I did. But no, I'm afraid it really hasn't. It hasn't been, like you've said, the whole way through about reflux. I haven't had that. I mean, it's just incredibly swollen.
Then I think that your compliance to the lifestyle changes is the paradigm for tonight. You're doing everything perfectly if you don't have any symptoms in your swallowing and stuff.
Yes, but the problem is that it's really impacted on my lungs. I mean, I just can't walk further than the front door. So that's kind of a problem.
But again, if that's the cause of sending you to the operation room, then you should be aware that this may not change after the operation. We are struggling about the scenario of having acute necrosis. That would be a yes, go ahead with your operation tomorrow. But if the respiratory issues is the only cause of sending you to the list, then this may not change after the operation as well.
I also was told by him that I have dialysis, so that's also impacted. But that's because of the hernia that I've got this dialysis. But so it's useful to know. Thank you.
Nicholas has asked if the recurrence of a hiatal hernia after an operation is related to the size of the hernia.
So there have been studies that show that the biggest the hernia, the highest the chance of recurrence. That's true. But there are also many other factors affecting that rate. such as the age of the patient, the comorbidities, the ability to heal, the ability to mobilize the esophagus towards the abdomen, which is not always easy because of the adhesions or the time, how chronic this hernia is. So many technical or patient-related factors are maybe the cause of recurrence. So it's not only the size.
Okay, that's great. Thank you. So has anybody else got any questions before we let Dr. Tanya go for the evening? No, thank you. Okay. Well, thank you, Dr. Tanya. That's been amazing. It's been really helpful, and I'm sure that many people are going to get some real good information from this.
Thank you for the
No, thank you so much for your time, and enjoy the rest of your evening. I know it's very late in Greece now, but thank you.
Thank you. Thank you for your
Thank
time.
you. Take care, everybody. Thank you for joining us.